Good morning, all. I am Dr. Vasu. Welcome to International Speaker Program webinar, followed by the panel discussion on the Tegoprazan, a new frontier in the acid-peptic disease management. So, with me, I have my colleagues, Dr. Krantikaran Pebili, Cluster Medical Head, Recura Division, Mr. Alpesh Rajnikant Shah, Head Sales and Marketing, Recura Division, Dr. Sunil Kumar Yadav, Team Lead, Recura Division, Mr. Prasad Jore, Head Marketing, Recura Division, Mr. Aniket Yashovardhan Misal, Group Product Manager, Recruit Division, Bushra Hassan Khan, Senior Regional Medical Advisor, Sandeep Singh, Head Sales, and R. Santosh, Head Sales. On behalf of entire Dr. Reddy's fraternity, it gives me absolute privilege to welcome eminent gastroenterologists across the country. We have Dr. Mahesh Goenka sir, who is going to chair today's session. He is the Director, Institute of Gastrosciences, Apollo Hospital, Kolkata, President of Society of Gastroenterology Endoscopy of India, served in between 16 and 17, and he is the editor-in-chief for the Society Journal of Digestive Endoscopy. He had numerous feathers on his head. Some of them are, he is appointed as a member of International Committee of American Society of Gastroenterology in between 14 and 16. He awarded with J. Mitra Award in 2005-6 by Indian Society of Gastroenterology for his contribution to gastrointestinal endoscopy. He is the Cisco Pentax Oration Awardee in 2002 by Society of Gastroenterology Endoscopy for his contributions of EJ endoscopy. Welcome and greetings, sir.
Thank you.
We have Dr. Randhir Sood, sir, who is the chairman of Institute of Digestive and Hepatobiliary Sciences at Medanta Hospital, Gurgaon. He is the Padma Shri awardee by the Government of India in 2008, established two large gastrointestinal centers of excellence in North India, Gangaram Hospital and Medanta. He is the Bharat Ratna Priyadarshini awardee by Delhi University. He is the Master in Endoscopy Gold Medal awardee by Indian Society of Gastroenterology. Welcome and greetings, sir. We have Dr. Parmel Lavite, sir, who is the Director of Department of Gastroenterology and Liver Disease, Jahangir Hospital, Pune. He is the Fellow of American Gastroenterology Society in 2018. He is the Fellow of Indian Society of Gastroenterology and Fellow Society of J Endoscopy of India. He is awarded twice in 2022 and 24 as Inspiring Gastroenterology of India from Economics Times. Welcome and greetings, sir. And we have Dr. Yushi Gosal, sir, who is the Senior Consultant and Chief of Luminal Gastro and GI Motility at Apollo Multispecialty Hospital, Kolkata. He is serving as Editor-in-Chief of the Indian Journal of Gastroenterology and also served on editorial boards of several leading gastroenterology journals such as Nature Reviews of Gastroenterology and Hepatology. He won a Warren Marshall Award in 2019, which were awarded by Asia Pacific Association of Gastroenterology. He is the WHO Fellowship at Prince of Songkhla University, Thailand in 2019. He is serving as the visiting clinician at Mayo Clinic, Scottsdale, USA. Welcome and greetings, sir. So with us, Dr. G.N. Ramesh, sir, who is Senior Consultant in Medical Gastroenterology at Aster Medcity, Kochi. He is serving as the Vice President and the SGEI active member of the APA and IMA Kochi. He is a life member of ISG faculty at ISG, INSL, SGEI. He is the founder convener of the Cochin Gut Club, published more than 50 research articles in national and international journals. He recently, in June 2025, taken as the charge as the first governor of Rotary District 3205, comprising Ernakulam, Idukki, and Thrissur. Welcome and greetings, sir. So we have Dr. Chung Han Ho, who connected us from South Korea. He will deliver session on Tegoprazan, Global Perspective. He is the current Director of Clinical Clerkship, College of Medicine, the Catholic University of Korea. He is the Professor, Division of Gastroenterology, Head of Clinical Division, and Director of Clinical Trial Center at Yunpyong St. Mary's Hospital, the Catholic University of Korea. He is serving as the Secretary General, the Korean Society of Neurogastroenterology and Motility, Vice Chairman, Editorial Committee, the Korean College of Helicobacter and Upper Gastrointestinal Research, He is the current secretary, examination committee, the Korean Association of Internal Medicine, and also the serving member of insurance committee, the Korean Society of Gastroenterology. Welcome and greetings. Now I would like to request our chairperson, Dr. Mahesh Goenka sir, to take us through the unmet needs in acid-peptic disorders.
Thank you, Dr. Vasu, and good morning, everybody. Am I audible?
Yes, sir.
Uh, Thanks for everybody for joining on Sunday morning for this academic program. And I suppose this is the first meeting related to Tegoprazan. We did have a couple of advisory board meetings, but this is the first open meeting of Tegoprazan where we'll be talking to the gastroenterologist and internist from all over the country, of this vast country from India. I'm very happy to be joined not only by the international speaker who is already here, but also Dr. O, but also by very important key opinion leaders from this country. And I was just looking at the list of Dr. Randhir Sood, Dr. Uday Ghoshal, Dr. Parimal Lavate, and Dr. G. N. Ramesh. And all of them are really key opinion leaders, not only in their regional area, but also overall the country and beyond the country as well. Interestingly, they represent 4 different zones of India, and Dr. O, India is a big country, and each zone is possibly bigger than your country. So we have from the west, Dr. Parimal Lavate. From south, we have Dr. G. N. Ramesh. From north, we have Dr. Randhir Sood. And from the east, we have Dr. Uday Ghoshal. So they would tell us the perspective in respect to not only the country, but also maybe some regional variation. See, when we have been treating acid-peptic disease and gastroesophageal reflux disease for quite some time, but sometimes we are bored with writing the same prescription of esomeprazole, pantoprazole, or rabeprazole for the last few years. So we would be discussing today whether it is just one new drug which we are talking about, or there are some essentials or improvement in the pharmacodynamic, pharmacokinetics, and clinical outcome with this drug. So my job is simple, to deal with unmet needs. Can I have the slide? Next slide, please. So there is a global increase in acid-peptic disease. If you look at scenario between 1990 and 2019, which is a period of almost 30 years, the incidence has increased by 75%. The prevalence has also increased by 77%, and years of living with a disability related to the disease has also increased. Now, if you look at global increase in the PUD prevalence, actually it's 25.82% in terms of peptic ulcer disease as contrast to gastroesophageal reflux disease, where the increase is much more. Next slide, please. So we also looked at the data from India, and as I wanted to say that the prevalence of peptic ulcer disease as a group in India is 38%, which is 1 in 3 people have suffered or suffering from acid-peptic disease. And the GRD prevalence in Indian population, it has been studied by many authors, many researchers, but overall we understand that 15% of the population is suffering from Indian population suffering from gastroesophageal reflux disease. Now, this data also shows the number of GRD cases which has increased between 1990 and 2017, and also that heartburn and the epigastric pain are the predominant features, predominant symptoms of GRD and acid-peptic disease respectively in our country. Next. So as I said, the PPI story began almost 35 years back, 1989, which when I was just completing my fellowship in gastroenterology in PGI Chandigarh. Before that, we only had H2 receptor blockers. So we got omeprazole and we thought we have got a wonderful medicine, and it is actually a wonderful medicine. But subsequently, there has been changes in the PPI pharmacokinetics with new molecules being put in the market, lansoprazole, 1991, pantoprazole 1994, rabeprazole 1999. Then we have esomeprazole and we have dexlansoprazole as well. However, next, there has been limitations of PPI, and we'll discuss these, which are whether these are actual limitations of using PPI is delayed onset. So when you use first dose of PPI in a patient with severe reflux disease on the day 1, even if you add a prokinetics or a drug like alginic acid, the patient doesn't get a relief, and it takes usually 3 to 4 days to have real symptomatic improvement. We also understand there's a meal dependency. All the PPI has to be taken before breakfast, and sometimes patients forget about it, and they have their issues about meal dependency. So we would look at that aspect as well. Night acid breakthrough, though it may vary, figure may vary from different studies, but almost 25 to 33% of the people have NAB. That means there's nocturnal acid breakthrough when you take a single dose of PPI in the morning. And this sometimes can be a major problem in GRD, and the patient possibly awakens with symptoms due to night acid break. The stability of PPI in the acidic environment is again a problem, and this is a paradox that it requires acid to act. At the same time, the molecule may not be stable in acid media. So that's something which we have been bothered about. And finally, genetic influence because of the metabolism which it goes through. So these has been the limitations of PPI. And I think we have been looking for some molecule to come forward and to settle some of these issues, if not all. Next slide. Next slide, please. So if you look at unmet needs of PPI treatment, this slide summarizes that 66% of the patients reflux symptoms persist after the first dose. And as I said, you require 3 or 4 days to have significant improvement. 50% of the symptoms persist even after 3 days. Heartburn and regurgitation are not relieved in 40%. Patients are taking twice PPI, and that is another point which we can discuss during this academic meeting, that significant proportion of the patient has to be put on twice PPI, and sometimes we add another molecules, maybe antacids, maybe alginic acid, maybe prokinetics to give relief. Next slide. So we also know that the PPI unresponsiveness in GRD can be there in 30% of the patients, because we may be dealing with a different subgroup of people, those with functional esophageal disorders. There may be issues of treatment non-adherence and non-compliance. We have weak acid, weakly acid or non-acid reflux, which can be important. There are residual acid, including acid pockets. And of course, we discussed about nocturnal acid breakthrough. So these are some of the reasons for non-responsiveness in patients with GRD, or we can call it refractory GRD. Next. Next slide, please. So PCAB, and this is a transition slide from my presentation to Dr. O's presentation. The PCAB has come in early 1980s. It's not a new concept, but then it was dropped because of the tremendous toxicity with these early molecules of PCAB had. And only in 2015, we had vonoprazan, and vonoprazan we have been using for last about 4 or 5 years. And then Tegoprazan came in the market, not in India, but in Korea in 2018. And then we have fexuprazan, which is also now available in India. The other molecules which are not yet, we are not familiar with, but maybe in the future we'll hear about Tegoprazan and other molecules. So here I will hand over to Professor O to take us to the story of PCAB. I just heard him telling that vonoprazan is now being withdrawn in the market. So I was a little surprised about that. And so we will listen and discuss about various PCABs, their importance over existing PPI, and what is the way forward. Thank you, Dr. O, for sparing your time to educate us. And I'm sure we all would be much wiser about the status of PCAB in our country. Over to you, Dr. O.
Thank you.
Thank you. Thank you, Mr. Chairman. Professor Mahesh Goenka, right? Very difficult name for me. And actually, I am very delighted and honored to be here in this webinar. And actually, I have been there, India, not full party everywhere, and only New Delhi, capital city, maybe 2012, 2013, just to take part in, participated in the small the conference. And I'm very thankful for the Indian doctor to give a chance to present this new novel clinically validated PCAB, Tegoprazan. I will give you the 3 parts. I'll give you a talk 3 parts. First one is the comparison proton pump inhibitor versus potassium competitive acid blocker. The second part, I will talk about the strengths of Tegoprazan, because now many Korean doctors use this new PCAP, Tegoprazan. Actually, the first PCAP in Korean market. And finally, I will talk about the clinical trials. As you know, PPIs are products that require activation by stomach acid. However, it should be noted that this compound only bind to active proton pumps, resulting in a slow onset of action. Its short half-life and instability in acid result in limited sustained action. In contrast, potassium competitive acid blocker is an active drug that binds to both active and resting proton pumps. It has a longer half-life compared to PPI and remains stable in acid and rapidly inhibits gastric acid secretion. This is the table to show the compare PPI and PCAP, Tegoprazan. And I would like to emphasize the time to maximal concentration. The Tegoprazan, it takes only 1 day. You know, the Korean, the people's characteristics, very short-tempered, and especially for Korean patients. And once they take a medication, they hope this symptom will be disappeared within a day. And so it is a good choice for Korean hot-tempered, short-tempered people. And compared to PPI, it reached 4 or 5 days to reach a good result. And let me move on to second part, Tegoprazan strengths. And yes, and first one is fast onset of actions. And already I told you this one. And second part is nighttime acid control. Third one is no food effect. And as you know, PPI should, before the patient should take this medication before 30 or 1 hour before eat. And fourth part is optimal pharmacodynamic for successful H. pylori eradication. Fifth part is low drug-drug interaction. And sixth one is various dosage forms. I will tell you later. Next. Sorry, I'm frozen. Okay. First one is fast onset of action. And so if you look at this graph, Tegoprazan rapidly elevates stomach acid level to greater than 4 within an hour and 30 minutes, a level that other medication requires 4 hours to reach. Acid-peptic, Tegoprazan, and vonoprazan here. This rapid action provides effective relief from GERD symptoms. How about NERD symptom relief, non-erosive reflux disease? Tegoprazan showed rapid symptom relief for patients to moderate to severe NERD patient with noticeable results from the very first administration, very first one day. And Tegoprazan also demonstrated this data about erosive reflux disease phase 4 study. Tegoprazan demonstrated accelerated healing and statistical superiority over lansoprazole, which is green one, Tegoprazan, which is a blue one. And after 4 weeks of treatment, indicating for the potential for more efficient treatment duration. Second one is nighttime acid control. Notably, nocturnal acid breakthrough is observed in patients taking PPI twice a day. The KCAP stands out from PPI due to its ability to provide sustained acid suppression even at night, effectively managing nocturnal acid breakthrough. Tegoprazan, which is blue line here, rapidly achieved a pH level of at least 4 within 1 hour and maintained it overnight, demonstrating superior nighttime acid control compared to vonoprazan green line here, and esomeprazole, which is orange line, is esomeprazole. The third part is no food effect. PPI needs to take 1 hour or 30 minutes before a meal to be effective. This timing requirement can be inconvenient, especially for patients with irregular eating habits, leading to poor compliance. Unlike PPI, Tegoprazan showed consistent acid suppression regardless of fast before 30 minutes, after 30 minutes, and regardless of dosing time. Number 4, optimal PD for HP eradication. Tegoprazan creates an optimal gastric environment for HP eradication from day 1. When taken twice daily, it maintains a significantly higher intragastric pH greater than 6 compared to pantoprazole. By the 7th day of treatment, Tegoprazan displayed enhanced acid suppression. It reaches 88% greater than pH 6 and compared to pantoprazole BID. How about DDI, drug-drug interaction? Because Tegoprazan is primarily metabolized not CYP2C19, but CYP3A4. Its acid suppress effect remains consistent across different CYP2C19 phenotypes. Please, next. Freeze. Okay. Okay, while esomeprazole significantly reduced clopidogrel exposure, tegoprazan did not show this interaction. Clopidogrel's the plasma levels were maintained when co-administered with tegoprazan, similar to level seen with clopidogrel alone. In patients undergoing PCI, percutaneous coronary intervention, and receiving that dual antiplatelet therapy with clopidogrel, there was no significant difference in platelet reactivity between the tegoprazan and PPI groups. And also, how about the DDI with atorvastatin? Tegoprazan showed no drug interaction when co-administered with atorvastatin, which is metabolized by CYP3A4. In contrast, the vonoprazan, which is light blue line here, significantly increased the systemic exposure of atorvastatin and its lactone metabolite. With tegoprazan, plasma concentration of atorvastatin and its metabolites remained stable. Also, tegoprazan has a low potential for DDI with NSAIDs. In a pharmacokinetic study, co-administration with naproxen, aceclofenac, celecoxib did not alter AUC values, suggesting no clinically meaningful interactions. The sixth part is various dosage forms. Tegoprazan has various dosage forms, several. And K-cap ODT dissolves quickly without the need for shaking and can be administered with minimal residue remaining in the syringe or nasogastric tube after rinsing. Now, in Korea, we have many the forms. And so tegoprazan is available in multiple easy to take forms, such as half dose, 25 milligram here, and standard dose, 15 milligram, and ODT. Also, it has two forms, 20 half dose and a standard dose, providing flexibility for different patient needs. And finally, I would like to talk about clinical trials. And we have many clinical trials regarding K-cap, tegoprazan. And first, I'd like to tell you H. pylori eradication phase 3 study. This one is somewhat old one. And so looking at the just 7-day H. pylori eradication result, unfortunately, the outcome was somewhat disappointing. Neither the PPI group nor the tegoprazan group achieved the eradication successful rate just around 70%. So let me show the very new study result. This important phase 4 trial directly compared the eradication efficacy of different doses of tegoprazan and lansoprazole. In this study, 14-day, not 7-day, 14-day eradication rates were evaluated for tegoprazan 15 milligram BID and 100 milligram BID and lansoprazole 30 milligram BID. Okay. Please pay close attention to this slide. H. pylori eradication rate was 86% with Tegoprazan 15 milligram BID compared to 78% Lansoprazole and 55 or 6% Tegoprazan 100 milligram. Interestingly, there was a little difference in eradication efficacy between the 50 milligram and 100 milligram dose of Tegoprazan, suggesting that the 50 milligram BID may be sufficient for effective treatment. To better understand this result, we need to consider the impact of clarithromycin resistance, which is shown on the next slide. Next slide, yes. Okay, this slide presents the eradication rate in patients with clarithromycin resistance H. pylori. The rates were 52% with Tegoprazan 50 milligram and 53% Tegoprazan 100 milligram, and just 38% with Lansoprazole. While both doses of Tegoprazan 50 and 100 showed relatively higher eradication rate here than Lansoprazole, the differences were not statistically significant because of the small number. And next study is about erosive reflux disease healing rate. This slide illustrates the design of phase 3 clinical trial. It was a double-blind, randomized, active control study comparing Tegoprazan with esomeprazole. Tegoprazan which is blue, and esomeprazole is green. The primary endpoint was the cumulative healing rate at week 8 here. The results show that Tegoprazan was non-inferior to esomeprazole across all LA grades. Importantly, in patients with more severe disease, the LA grade B, C, D, Tegoprazan demonstrated significantly higher healing rates. Also, evaluate Tegoprazan 25 milligram versus Lansoprazole 15 milligram for maintenance therapy in patients with healed erosive esophagitis. After 24 weeks, endoscopic remission was maintained in 91% of patients on Tegoprazan and about 90% on Lansoprazole, confirming Tegoprazan's non-inferiority. Tegoprazan half dose 25 milligram demonstrates significantly higher endoscopic remission rates than Lansoprazole 15 milligram in patients with LA grade B, C, and D. How about safety result? According to safety data, Tegoprazan showed significantly lower rates of adverse drug reaction and serious adverse events compared to Lansoprazole. These findings suggest superior tolerability of Tegoprazan. Tegoprazan also did not increase serum gastrin level even with long-term use. This study was conducted in patients with NERD patients. Tegoprazan 50 milligram were compared with placebo over 4 weeks. Here, the primary endpoint was complete symptom resolution at week 4. Here, the percentage of patients achieving symptom relief was significantly higher in the Tegoprazan group compared to placebo. At week 4, Tegoprazan demonstrated the highest level of complete heartburn relief in null patient, reaching 62%, outperforming the PPI here. In contrast, omeprazole, esomeprazole, rabeprazole, and dexlansoprazole showed lower efficacy rates ranging from 33% to 55%. So let me show the result of gastric ulcer, page 3. This slide, the Tegoprazan showed a 100% healing rate after 8 weeks of treatment, was proven to be non-inferior to lansoprazole. Tegoprazan marketed under the brand name KCAP. I heard the brand name is PCAP. So PCAP is a potassium competitive the acid blocker. It's a very good brand name, I think. It's launched in 2019 and has become the second most prescribed medication in Korea as of 2024, last year. This is lineup, and the final slide. One of the key strengths of the Korean PCAP, KCAP, Tegoprazan, is broad range of approved indication, including the GRD for GERD for ERD and NERD and gastric ulcer, H. pylori eradication regimen, and maintenance of healing of erosive gastroesophageal reflux disease. And also we just completed the study about the prevention of NSAID-induced the ulcer and just finished it. So we hope to the prevention of NSAID, and so it will be a good news for clinician. Okay, thank you for your listening.
Thank you, Professor Ho, for this wonderful deliberation and telling us about your impression about this new drug, new for us, Tegoprazan. We have, as we discussed, a very senior faculty from India, and we decided to take their opinion about some of the aspects which you talked about, including the Indian perspective. So can I start with Dr. Randhir Sood? Now, Randhir, we have been talking about, you can avoid showing the slides. Can you just project the people? All right. So Randhir, can you tell us about, we've been talking about rapid onset of action and the rapid drug levels, how important it is. Does it matter whether the drug level reaches high in day 1 or day 2 or day 3 or day 4?
You see, it's Mahesh, the most important area where this matters is, as per need intake of PPIs. Like in a patient of NERD who needs, symptom relief immediately, conventional PPIs are not very good because they will take at least a couple of hours to start acting. And but with the PCAPs, particularly Tegoprazan, as Professor has shown, that there is instant onset of action, and that action lasts for more than 24 hours. So say somebody goes to a party, has flux symptoms, he needs to take something, he needs the relief immediately, and that relief which lasts. This, to my mind, will prevent many people from taking PPIs regularly. There are huge number of our patients who are taking PPIs even without prescription, and just because they are wanting relief when it is needed. So I think as per need, SOS need of acid symptom control, particularly in GERD, is the first most important aspect where immediate onset of action will be
Randhir, if
important.
you can
Second will
extend
be
that question
GI
further.
bleed.
Yes, sorry, Randhir, carry on.
The second will be patients of GI bleed who can be given oral therapy, and where the immediate onset of action and the increase in pH will be very important. So these are two aspects, I think, where this particular attribute of PCABs, particularly Tegoprazan, is important.
So I would extend that question, and I would like Dr. O to join, is that you talked about oral ODT. Do you think ODT is a good option in patients with GI bleed rather than giving them the regular drug, regular Tegoprazan? And Randhir, I often see general practitioners and internists, I don't think where there's evidence that they give intravenous PPI, existing PPI in this situation to achieve quicker results. So do we have any thought process about these two aspects? Dr. O first.
Yes, thank you. Very good question. And so, yes, I think so. And ODT is very good option for some patients, even the NG tube. But after the bleeding situation, and so it will be good effect. But now the Korean doctor now are researching about the intravenous PPI versus double dose PCAP, like that. PPI intravenous BID versus oral PCAP. But I'm not sure this is which is ODT or not. Just I don't think it doesn't matter the ODT or whatever. But the Dr. Randhir should already told the bleeding prevention is very good option for PCAP because it the strongly and rapidly gastric acid suppression. And so I think it's very good option for control the rebleeding of
I think Professor O, the conventional teaching for managing the GI bleed, non-variceal GI bleed, ulcer bleed has been using intravenous PPI. So we do not have possibly data even from Korea where intravenous PPI conventional has been compared with ODT Tegoprazan in this situation. We have a lot of physicians and the gastroenterologists attending this session. So do we have enough data to change our practice from IV PPI in a patient with non-ulcer, non-variceal bleed to oral Tegoprazan?
Yeah, but actually I don't have the data result. But do we have the result for the prevention, the rebleeding rate, non-variceal or such opportunity bleeding? Maybe we don't have. Compared to
this will be something to work on the future as the whether we can switch, because we had some data from India, Kashmir, where we had shown some time back, almost 3 decades back, possibly, that oral omeprazole is as good as IV drugs.
Yes.
Controlling PPI, controlling bleed.
Yes.
Let's move on to the another area. So I think this is an area where we can work and look at in the future whether we can allow oral Tegoprazan to be used in place of intravenous.
Yes, I think so.
Answering your question, which is very relevant to the general practitioners who are listening, of IV PPIs for relief of abdominal pain, particularly even non-acid related symptoms. I think this is an overkill. There is no evidence that IV PPIs act faster, and the relief in the acid-related symptoms are really accelerated if you give it intravenous. And
I think this is a very important message, Randhir, but you would agree that we often see prescriptions where patients have given IV PPI, even in emergencies, when they come with something.
Even in tertiary care hospitals, in emergencies departments, this is a routine.
GN, quick comment, please.
Yeah, no, I think the one that you covered up, even in emergencies in advanced or advanced institutions, the first thing which the emergency physician does when a patient comes with an acute abdominal pain is give an IV PPI. I mean, that is there in their protocols for some reason. I don't know. It's not really backed by any evidence.
I think let me move on to another very important issue, and we can discuss it in length, is about NAB, nocturnal acid breakthrough. And I would request Dr. Uday Ghoshal to give his perspective about how common is this problem, how do we manage it till now, and what do you think this new PCAB is going to change our practice? Uday.
Yeah, a very important question that you asked. NAB is quite frequent. In fact, in 3 of our studies, or 2 studies published in Indian Journal of Gastroenterology and 1 in Journal of Neurogastroenterology and Motility, which get published from Korea, almost a third of patients with GRD, they had nocturnal acid breakthrough. This is because the PPI, they don't work in sleeping pump. So in the night time, the PPI doesn't work so well. Also, when we give a dose of PPI in the morning, by the night, obviously the drug level has gone down. So there is a breakthrough of acid, and there could be even esophageal acidification and symptom. And typical symptom would be patient will get up from the sleep, maybe he will take some antacid, and maybe he may or may not have heartburn. Now, this is because the PPIs are short-acting. On the other hand, if you look at Tegoprazan, which is a long-acting drug, it is expected to cover the acid suppression more consistently and over a longer period of time. And therefore, NAB would be prevented. And in fact, we did not have PCAB at those times when we did the study, but we used drugs such as PPI, which are long-acting, and compared them with drugs such as omeprazole, which is short-acting. And we found even with long-acting PPI, there is a reduction in the nocturnal acid breakthrough. And now, not from India, but from many other countries, including Korea, you have multiple studies to show that PCAB, including Tegoprazan, actually prevents nocturnal acid breakthrough. So therefore, I would say this is an extra advantage of PCAB over PPI, because nocturnal acid breakthrough, which occurs about in a third of patients, and in some series up to 70%, could be prevented by using PCAB such as Tegoprazan.
I have a question here. Dr. O, do you have Tegoprazan available in Korea?
Yes, we have.
Now, whenever we talk about the pharmacokinetics, Tegoprazan is supposed to have a longer half-life as compared to Tegoprazan. So is it just the half-life which matters when you look at the duration of action, or is it how the molecule binds with proton pumps which matters, or whether everything matters? So does one PCAB is better than the other PCAB when you talk of nocturnal acid breakthrough? I know it's a very sensitive question, but
very
we must
difficult
answer
question for me. But as far as I know, half-life is a pharmacokinetic term, while the actual pharmacodynamic effect, which is efficacy or duration of action. Yes, you are right. The Tegoprazan, it has longer half-life than Tegoprazan. But although Tegoprazan has a short plasma half-life, I think approximately 4 or 5 hours, is pharmacodynamic effect, which is gastric acid suppression, lasts considerably longer, which is, in other words, Tegoprazan maintain an intragastric pH greater than 4. Its data shows for approximately 65% of the 24-hour period. And so it does not, I think, possibly does not correlate the half-life and still the action.
Okay, thank you for clearing that, Dr. O. Now, Dr. Parimal Lavate, we have been telling our patients to take PPI 1 hour before the morning meal. Sometimes the patient forget about it. Sometimes they take it after that, and we know that the results may not be good because you want the PPI, the pumps to be available for the action. So, do you think this issue where the timing in relation to the meal does not matter when you take a drug like to reduce your acidity, acid formations, do you think this is of clinical significance?
Yes, I think to me, if you look at the list of advantages which are discussed about PCABs, from a practical prescribing perspective, this is a very important benefit which we have with PCABs because the final effect will not get affected by food intake. So this is really a practical and very important effect of PCABs, which will translate really into clinical practice and clinical benefit to patients.
So there are a couple of questions on the chat box. We'll take that. So do you think in the same related to the same thing that there are some patients who should be given PCAB like Tegoprazan in the evening so that it not only covers the acidity in the daytime, but maybe covers it better in the nighttime also? So should you give selective patients who have the problem of nocturnal acid breakthrough evening dose rather than the morning dose?
I think I do it in clinical practice because we give it when the patient is most troubled by the symptoms.
So, Dr. O, what is your practice? Do you have a subset of patients who complain of nocturnal acid breakthrough and you want to give them Tegoprazan? Will you give them double dose of Tegoprazan or will you give a night dose of Tegoprazan rather than the morning dose?
I will. I chose the latter one, and so I don't think double dose is quite somewhat is. I'm sorry, and I usually give the nighttime only, and twice a day is somewhat. Too much. I think too much. Yes.
All right. So
if you have been one of us,
yeah, sure.
And there are patients whom we give single dose and they do get up at night. So although we talk about PCABs as very long acting, in practical experience, we do have patients who get up at night to give a single dose. And those patients, maybe you can select for bedtime.
Parimal, only thing is that we do not have much experience with the Fexuprazan and Tegoprazan. We are talking only about Vonoprazan.
Yeah.
So I think with these two new PCABs, maybe the situation will be different. Ragdev, you have a quick comment. Dr. Vasu, can we extend it by 5 minutes? Dr.
Yes,
Vasu?
sir. Yes, sir. Yes, sir.
All right.
Okay.
Mahesh, if you go into the history, H2 blockers were always given bedtime. And for peptic ulcer disease, that time GERD was not a major issue. And then we shifted to fasting and before meal because of the unique pharmacokinetics of PPIs. And I do not understand why when there is a total independence from meal, we should not go back to nocturnal, dosing because that will be the most vulnerable period for the patient. So I actually prefer to give it nighttime.
So, Ranveer, as a corollary to that, when we are treating nocturnal acid breakthrough, we cannot forget that majority of them has daytime problems.
But then you say that the symptoms are controlled.
Oh, but that's right. See, try to understand. Whatever acid-related symptom will occur, major symptoms are daytime. This is related to meal of different kind, stimulation of acid secretion by site of the food, related to psychological issues and so many others. Now, question is therefore, if you give nighttime dose, maybe you will be able to control NAB very well, but NAB is the symptom which occur when daytime things are controlled, and now patient come to you with night symptom in addition. So I would say, yes, you can give an H2 blocker at the night, or you can divide the dose of PCAB, half in the morning, half in the evening, if you are not really interested to over-suppress the acid.
I think it's a very interesting area, and more work is required on this as to what is the best way to control nocturnal acid breakthrough. But don't forget, not forgetting that the major symptoms are in the daytime also. Now, GN, another area, and I think this is, to me, looks to be a very, very exciting area for the new PCAB, is using them for H. pylori eradication. Whatever we do, our eradication rate by using these combination is not beyond 50% or 60%, not even 50%, because of clarithromycin resistance, which is emerging as a major problem in our country. So the data suggests that PCABs, because of their ability to correct the pH even better, so the pH goes down and pH goes up even more than 6, they may be, and this is what is important for H. pylori eradication, so that this is one area where I think we are very excited to use this PCAB, because it's very frustrating when you give the patients a first dose of drug, he comes back, you test him again, and it's still positive. You give him second dose, it's still positive. You try bismuth, and the bismuth has side effects. So I think this is an area. Unfortunately, the local authority, DCGI, has not given the clearance for these new PCAB for H. pylori eradication. But we can do it as a study and then possibly talk to DCGI that this is the area where we need to work. So what do you think, GN Ramesh, about H. pylori eradication and these new PCABs?
I think, thank you very much, Mahesh, for this question. I think it's a really exciting time. Informally, I think if you ask a lot of gastroenterologists, probably they've started using PCAB for in combination for H. pylori eradication. Personally speaking, I've also started using it, and I find the results good. But I'm not in a position to say, are they better? Have they offered any definite superiority over the regimes that we have been using? And this is an area that we must try at the earliest, because I'm sure the results are probably going to be better. There are also the advantages that they can all be given together, and since it is independent of meals, that also makes the administration also more simpler. I think all the aces are with this particular combination, and I think we should be trying it in patients with H. pylori infection.
So there are a couple of questions in the chat box, and before we proceed with the specific questions, does PPI, including Tegoprazan, have effect on the gastric emptying? So Dr. O, what is the effect on gastric emptying? And do we add prokinetics when we are using this in GERD?
Yes, thank you for a good question. Yes, I'm sure PPI delay gastric emptying, right? But we have a data about the relationship, the gastric emptying and Tegoprazan for healthy control, but it does not delay gastric emptying when we use Tegoprazan. And so it's a small data, but I saw there's a DDS recently, and so yeah, the Korean data, yes.
Uday, you have anything to say on this?
Yeah, both PPI and PCAB can delay the gastric emptying. They can increase the gastrin level. They can change the gastric microbiota. But also 1/3 of patients who have acid-related symptom, be it functional dyspepsia, be it GERD, they have delayed gastric emptying. So it is there in the baseline, not necessarily because of PPI or PCAB alone. So in India, typically most would say that start with a PPI plus prokinetic rather than giving PPI or PCAB alone. Probably this will continue in the practice, maybe overkill, but still this is what physicians like. But in general, the scientific data to randomized control trial showing on one limb you have given PPI plus prokinetic or PCAB plus prokinetic, or other limb you have given only PCAB are lacking.
Dr. Lavate, we heard Dr. O talking about cytochrome P219, C19, and other related issues. Do you think that really matters in our day-to-day practice? This clopidogrel pantoprazole story has been moving around, and we were told at some time that we are committing a crime by combining the drug, but later on it was told that it is not such a big problem. So do you think that the different metabolism of the new PCAB, particularly Tegoprazan, will have an effect on our co-prescribing with drugs like clopidogrel, atorvastatin, or even clarithromycin?
So if you put things into perspective, initially we had these reservations, but then you had the NEJM Cogent trial, which showed that it really doesn't make any difference whether we give PPI along with CYP2C19 clopidogrel. So we have been really not strongly recommending that you should not give it. But having said that, cardiologists do have their own reservations, and they prefer to use a PPI or they prefer to use something else. So it may have a theoretical advantage, but I don't think evidence-based we can say that PPI and clopidogrel have a bad interaction. So they would have a theoretical advantage. And if you ask me, I think our cardiology colleagues are more concerned about this interaction. And things we tell them actually, if at all they are concerned about it, is to give one in the morning, one at night, or use a H2 blocker or something like that. But theoretically, you can use them together.
So maybe you can now talk to your cardiologist colleagues and say that let's use Tegoprazan or PCABs rather than the traditional PPIs.
Yeah, I think they would take it up more than us. Like I said, after that Cogent trial, Dr. Uday can comment on this. But after that, it has been kind of settled that they don't really lead to a meaningful interaction.
Yeah, but other than the interaction, there is an issue. If you look at the Western population, 95% are wild as far as CYP2C19 is concerned. If you look at Indian population, there was a big study published from cardiologists, which showed that 1/3 are CYP2C19 polymorphism homozygous. Another 1/3 are heterozygous. So that means 2/3 of Indian population are CYP2C19 mutant. And therefore, this population PPI action is unpredictable. So because we did not have a choice of PCAB, that's why relying all on PPI. But probably now with PCAB, this is an extra advantage in an Indian population.
So Uday, are you suggesting the DRL people to meet the cardiologist more than the gastroenterologist?
No, obviously they should not, because ultimately all acid-related disorder, final authority is a gastroenterologist.
But then I think we should be using a 10 milligram dose for them. I mean, the equivalent, the lower dose of the PCAB.
25 milligram.
Yeah, I think that makes sense because it is typically known that parietal cell mass of Indian population is lower, and because of H. pylori gastritis, our acid secretory capacity is lower.
So we have extended our time. I would have to close it. So final comment from Dr. O. Any final comments, Dr. O?
Yes, I just share the experience, the strengths of KCAB, the Tegoprazan. When you use the patient with the maintenance therapy, the on-demand therapy, usually we want to stop this medication because they already don't have symptom and cure the esophagitis. And so why don't you stop? And after having this medication, you can have faster onset of action. And so they agree because it has very fast onset of action. So when you feel the heartburn, regurgitation, just do not, no food effect, and whenever just once a day, you can take this medication. I usually, told the patient like that.
So quick comments by the panelists, Dr. Randhir Sood.
Yeah, I was talking about the CYP2C19, the story. In fact, it is more important that, the 3A4 suppression and it's effect of these other PCABs on A34 which is not happening with Tegoprazan. So the more drugs are metabolized through that system than CYP2C19, and particularly statins and many chemotherapeutic agents. So I think it's very important that drug which does not have any suppressant or promoter effect on a particular coenzyme, which is the common pathway, is a safer drug. You can predict the response. So that is an advantage of Tegoprazan over other PCABs.
GN?
I think, I think you started off with a list of unmet needs, and if you look at Tegoprazan, it actually meets all the unmet needs, and so therefore, I think we have a bright future ahead of us, but we need to try it out in our population.
Parimal?
Yeah, I think like we discussed the faster onset of action, long action, and lack of drug interactions with. But you have to remember about drug interactions with the other group also, where also this scores. So on all these counts, I think it definitely scores better marks than the others. Now let us use it and see how it works. And we will be, I think, lost in a discussion about which PCAB to choose later on and see what our first
we can have a meeting. Let's do a comparison between the various PCABs, because we participate in the various webinars by various companies and talks about various PCAB. But I think we need to make up our own mind as to which is the best. Uday, you have any warning for the audience? I mean, is more always better?
Yeah,
So
you see,
more suppression of message, is it always good?
Yeah, see, PPI, the problem has been that we are talking about de-escalating PPI because often this is misused. I worry that whether this will happen with PCAB as well. PCAB is a very good weapon, but used when it is needed. Second is, I agree fully, H. pylori is real unmet need. The eradication rate with the kits that are available in the market, we have now data of more than 100 patients, is less than 10%. So that is an area where really PCAB is going to go much above the PPI-based therapy. Nocturnal acid breakthrough is important, and that we have already discussed.
Uday, you are presently the president of Indian Society of Gastroenterology. We had a guideline, I think, on PPI, the use and abuse, which was published a couple of years back. We had a guideline which has been published by API, Association of Physicians of India, on vonoprazan, published only recently. Do you think we are in a position to talk about PCABs through ISG, or it's a premature?
Yeah, no, I think we should talk about, because use is to be sort of spoken when it is indicated. Also, misuse has to be discouraged. And the misuse not only by the doctor, but by the patient. They go over the counter and buy this PPI. Maybe same will happen with PCAB, which is not a good practice.
So with that, we would close the session. Thank you, Dr. O and Dr. Randhir, Dr. Ramesh, Dr. Parimal, Dr. Ghoshal, for this discussion. I think we touched upon most of the points which were in our mind. Dr. Vasu, back to you.
Yeah. Thank you, sir. Thank you for providing a comprehensive understanding of the topic. Now, I would like to request Dr. Kranti and Alpesh to please extend the regards to our chairman and also the panelists and IS. Over to you. Yeah.
Yeah. Thank
the
you
only
very
thing
much.
Before Kranti says, Kranti seems to be traveling all the time.
Sorry. Yes, I'm in a flight about to take off.
Yeah.
Yes.
So, sir, I would like to put across my heartfelt thanks to all the panel members, starting with Dr. Mahesh Goenka, Dr. Randhir Sood, Dr. Parimal Lavati, Dr. Ramesh, and Dr. UC Ghoshal. And also a special thanks to Dr. Who has joined all the way from Korea to give us the glimpse of the molecular science behind it, and then all the panelists for giving us the directional sense on how to be used and how cautious to be used and where to position the drug. We're looking forward to having many more scientific discussions going forward in the future. Thank you, sir.
I think good afternoon, doctors. First of all, I would like to thank you on behalf of entire Dr. Rizvi's head office to Dr. Mahesh Goenka sir for chairing and moderating the session. And eminent panelist member Dr. Randhir Sood sir, Dr. Uday Ghoshal sir, Dr. G.N. Ramesh sir, and Dr. Parimal Lavate sir. I think it is very difficult to get all of you on one screen for one program. and it was on the best way to launch, I think, Tegoprazan in India. And special thanks to Dr. O and our Korean partner HKI and Jewon, I must mention, for I think helping us to conduct this inaugural international speaker program for the launch of Tegoprazan. I think thank you very much everyone for taking out your time on Sunday morning and joining this program. And my special thanks to fantastic audience. I think taking this session, and I think a lot of questions also being asked by the audience, and it has been taken up. So thank you very much everyone. Wishing you a great evening ahead. Thank you.
Thank you. Bye-bye.
Thank you, sir.
Thank you, sir. Bye.
Thank you. Bye.
Bye.